In this final segment, we are going to be discussing specifically the role of bone-targeted therapy in patients with prostate cancer. So historically, in terms of urologists, we have sort of looked at bone health, and the urologists have been very active in this probably over the past 7 or 8 years. We know that there's 2 areas of bone health that come into play. First of all, patients that get started on androgen deprivation therapy, primarily for biochemical recurrence after definitive treatment. They get started on ADT, and it sort of sets off this whole cascade of events, which includes pseudometabolic syndrome and an increased risk of osteoporosis, something that we've recognized as what we call cancer treatment-induced bone loss, or C-Tibble disease. We also know, though, unfortunately, that when patients do go metastatic with prostate cancer, about 80 to 90% of the time, one of the early places that they go for lots of different reasons is really the bone. And again, there's a lot of data. I know at your institution, Mike, that they're doing a lot of looking at what are some of the factors that why prostate cancer has this predilection for bone. Can you give us, the audience, any thoughts on that in terms of just global 30,000 view?
Yeah, I think it just continues to sort of seed and soil hypothesis, and a lot of different candidate cytokines, and sort of even how denosumab came about in terms of the role of rank ligand, the osteoclast osteoblast interactions, but now sort of even just bone marrow cells and sort of what they're secreting to sort of also affect that milieu continues to really be an active area of investigation. And yet, how you target that, we have made a lot of progress with drugs that sort of, reduce some of the benefits, reduce some of the effects that you've talked about osteopenia and osteoporosis. And many of our active drugs that are anti-tumor are also those that reduce skeletal-related events. So we have a much wider range of options to sort of reduce skeletal-related events.
So Glenn, as a radiation oncologist, we know that it's interesting. We've gone from which we still do. We use spot welding for patients with isolated lesions who are symptomatic. We've used beta and gamma emitters that were mostly palliative, and now we also have a alpha-emitting radiopharmaceutical, Radium-223 or Xofigo, that has really nice profile. Can you comment a little bit about your experience with radium and differentiate it, if you will, to some of the previous used betas and the gammas that were palliative in nature?
Sure. When I bring up radiopharmaceuticals at a tumor board, particularly the older physicians that had a lot of experience with strontium or samarium, they just want to run out the door because there was tremendous toxicity, and it has to do with physics. The beta particles will affect the surrounding tissue, which is the bone marrow. The radium-223 is an alpha emitter. These are huge, alpha particles are enormous. They have a very high linear, it's called LET, so you're depositing the energy at a very small amount of tissue, probably within 8 to 10 cell diameters. It's a calcium emetic, so it gets taken up where there's a lot of bone remodeling, where you see the metastatic disease. And so the Alcimca trial, which was a very large trial, more than 900 patients, showed that there was an improvement in overall survival. There was a delay of skeletal-related events, and they defined that as an event requiring external beam radiotherapy, a spinal cord compression, or if radiology had to orthopedic surgery had to intervene. That was a very important study because we can use that drug, and vis-a-vis the conversation we've had about layering, it seems to be very safe, so you can deliver it for patients. The Alcimca trial required patients to either have had chemotherapy with docetaxel or were not eligible or had refused. But the patients that got docetaxel did very well in terms of myelosuppression. There's studies that show that you can give chemotherapy after the use of radium-223. And there's a lot of emerging data now using it along with some of the other drugs like enzalutamide, and it seems to have a very safe toxicity profile. So utilizing it early on is really critical. We know that more than 90% of patients that have castration-resistant disease do have metastatic disease. Now, maybe we don't see it because I think that the typical imaging, like bone scan and CAT scans, are somewhat limited. Using more sophisticated studies like sodium fluoride PET, you will often find it. I think the choline PET CT, the C11, is a very nice study. The problem with the C11 is that it's such a short half-life that if you don't live right near a cyclotron, you're going to have issues. And patients often are scheduled and it has to be canceled because of a time delay. The Exumin PET CT. So I think with the newer PET CT imaging, we're going to find disease earlier on. And I think it's quite appropriate once patients have symptoms that this drug be considered.
So that's sort of an important point because it's like you said, is that the indication is it is approved for patients with metastatic castration-resistant prostate cancer with bony metastases. They can have no visceral metastases, but they can have limited nodal disease. And so the question, though, and Neal, if memory serves me, didn't you give the first commercial dose of Radium-223 in the United States? And so give us some background on how you are looking at these patients, because again, as we've talked about, it's where to fit these therapies in. And sometimes, just like CYP-T, sometimes just like radium, you got certain windows, and then if you miss that window of opportunity, it's gone. So from a, quote, minimally symptomatic standpoint, sort of what are you teasing out from your patients beyond just, quote, pain and the use of analgesics?
So I think Glenn did a great job summarizing the Alpha-emitting trial, and your question about symptomatology is really important. There's a lot of subjectivity to this notion of symptomatology. In the Alpha-emitting trial, there was a really wide spectrum of patients who were symptomatic, and they could have been on Tylenol, acetaminophen, to a fentanyl patch, morphine, or just taking a COX-2 inhibitor or an anti-inflammatory. And it was almost like a 50-50 breakdown in the patient population. Bottom line is they had to have more than two or more bone lesions. About 85% of the patients had more than 6 bone lesions. When I first gave the first dose, and probably the first 90% of patients I gave, they were all post-chemotherapy because they had nothing, they'd received everything else. Now, in the last 2.5 years, it's 90% of my patients are all getting it prior to chemotherapy. And why do I do that? And I give chemotherapy, and I'm a big believer in taxane-based therapies. But we use these words very well tolerated. Well, Radium-223 is extremely well tolerated. It is a 45 to 60 second injection. There's no pre-med, there's no post-med, and the adverse event profile is exactly what you saw in the Alpha-emitting trial. It is low single digits, some mild diarrhea. You can get some myelosuppression, again, low single digits, doesn't preclude giving chemotherapy later on for all practical purposes. So the window that you talk about, it's 6 months, because you want to give a minimum 5 to 6 doses to get a full course. The data suggests anything less than that, you're not getting the survival benefit. And make no mistake, unlike strontium and samarium, this is not a drug you give for palliation. This is a drug you give for survival prolongation. So as Evan was saying, you want to give a survival prolongating drug, you want to prevent complications, and you want to preserve quality of life. It does all three. And what I like a lot about it, and what we've done at my clinic and my shop, that we've done 2 phase 2 studies where we've layered. The first one was layering abiraterone. By layering, we combined radium and abiraterone at a minimum. A third of the patients had been on Abi for 90 days, and it showed no progression. And the other 2/3 of our patients, we did approximately 40 patients, we started concomitantly. And we have that paper, it's submitted for publication now. I presented that data at ASCO GU and at AUA, showing tolerability, no adverse events. My point is Radium-223 Xofigo is truly a drug that was designed, if you listen to Chris Parker, the first author on the New England Journal article, it was really designed to be combined with other therapies. So I would like the listening audience to take 2 messages away. One, this is a drug not to be given for palliation of symptomatology, although you'll see that, but it's for survival prolongation, and it really lends itself well to combination, layering, whatever verbiage you like. The rate limiting step is going to be accessibility and affordability.
I think that is again, it's important to understand that is that this is a drug that should not be viewed by our peers and colleagues as a palliative agent. It's a drug that has a defined survival benefit, as Glenn said, with the Alcimca trial. But we also know that in order to get that survival benefit, you should get at least 5 or, you should complete the 6 doses, because it's an injection every 4 weeks for 6 months, and that there is clearly the benefit with 5 or 6 injections. I think your point is well taken, Neal. And Glenn, as you talked about, that we know that it's a bone-targeted therapy. We are not doing anything in terms of this particular agent by itself to target what, again, getting back to the androgen receptor axis. And again, I think that's a really good point, is that it probably should be designed to be used in combination.